Well, I'd like to welcome all of you to this lunch symposium on innovative solutions for presbyopia and refractive errors. I'm sure it's going to be a marvelous session. And we've got a host of great speakers giving topics which are wide-ranging. So I'll really give you a whole range, and then we can have a little discussion at the end of it while we still have the time. I'm going to start off. Is Dr. Kamal Kapoor, my moderator, with me? Not yet. He's still coming. Okay. In the meantime, can I invite Sanjay? Is you loaded? May I invite you to get the ball rolling with the Zepto Rexus pros and cons. As you are all well aware, Zepto is a great alternative to to utilizing femtocataract. And one of the biggest advantages of femtocataract is the fact that you can do a good rexus. And a rexus is very important in two places or three places really. Number one, in children, it makes a world of difference. A good rexus means you can manage to put a lens in. A bad rexus means the child forever and evermore is not going to see well. The second, of course, is a white cataract, a white intumescent cataract. There's nothing really to beat a femtorexus. And third, something people don't normally talk about, and that is rock hard cataracts. Rock hard cataracts have very thin capsules. And if you cannot do a good rexus on it, you are doomed to failure for two reasons. One, your capsule at the back will trample in and give way. And secondly, the lens is going to be sitting on the retina, and you're going to make one person very happy, the retina man, and one person sad, your patient. Having said that, now on to Dr. Sanjay Gadre, who's going to talk to us on Zeptorexis, which gives all the benefits at a fraction of the cost. Timing, kitne hai? 1, 2, 3, 4, 5.
Excuse me,
10
slides.
minutes, 50 minutes we've got? No, we've got 45 minutes. 8 minutes.
ये slides कहाँ हैं?
Sit where? What's the difference?
Yeah.
I'll sit.
Yes, sir. Thank you, sir, for giving me this, and the care group for giving me this opportunity to share my experience with zeptocapsulorexis in first 150 cases. I would, of course, be discussing the pros and cons of the procedure. The principle of this particular technique, as you know, is a precision pulse capsulotomy. So very little energy is utilized. Only for 4 microseconds, the energy is utilized to create this. And so it's an automated disposable capsulotomy device. It has a circular nitinol ring covered by a thin, soft clear silicone suction cup shaped like a miniature inverted frying pan. Nitinol is a super elastic shaped memory alloy which forms an inner ring, and zeptosecond is actually 1,000,000 times smaller than a femtosecond. There is a silicone suction cup around which is about 6 millimeters diameter. So without going into too much of technical details, I think I would start with this mostly a video based sort of a talk. And an ideal case for a beginner would be a well dilated pupil, nuclear sclerosis of 2 or 3, an uncomplicated zonular status, and a good corneal clarity. Sorry. Why video? It's running there. It's not running here. Okay. So this is an ideal situation where you have dilated pupil and you have now centered it well. You have to see that the Purkinje images are in the center of the ring, and then you have suction so that the bubble movement is seen. And once that stops, then the 4 millisecond current is passed, and then the suction is released, and the capsulotomy is mostly it's free floating and it's out. One of the advantages that I found with this particular technique is that the hydrodissection is minimal, because what happens is that the capsulorhexis is actually is pressed down and it's not elevated like you do in manual. So there is no leakage of fluid. So you have to do a gentle hydrodissection and it serves the purpose. Can we move ahead? आगे नहीं बढ़ रहा है भैया. Yeah. So it definitely has a clear advantage in potentially complicated cases, such as hard mature cataracts or intumescent cataracts, as just sir said. There could be a coexisting pathology that there is a corneal scar and you are not able to see inside, and there is a cataract, or in posterior polar cataracts as well. I'll come to that later. Now, there are young patients who come with such type of intumescent cataract where there is very high intralenticular pressure, and in this particular situation, this is an extremely useful tool, because you can center it well, and you know the current that is passed is all around the ring, and therefore it is never that the capsulorhexis is not intact. And once the capsulorhexis is intact, then everything becomes quite easy in these patients. This is the 5 millimeter ring that you can get, and if your centering is proper, that's so important, then the lens is covered on all sides by the rhexis, and therefore the centration of the lens stays good for years together. And this is especially, we have been promoting this especially when we are doing the premium IOLs like the Toric or the multifocal or multifocal Toric. But all are welcome actually to get this procedure done, because it's not very expensive, and let us accept that in phaco, I think capsulorhexis is the thing. If you are able to do a good capsulorhexis, 90% of the job is done. So another situation where this is very useful is if there is a corneal opacity. Here the opacity is not very dense, but the visibility is poor. So you used to stain the capsule, that was one thing. And in that, we tell the patients that this would be really useful, because if you can't see also, when you see the Purkinje images, you can center the ring well, the Zepto ring well, and do the rhexis. So once the rhexis is done, I think so many times we are able to blindly actually complete the phaco, because we are so used to the procedure that, and once your phaco is perfect, then placing an IOL is not a big problem. So in these situations also, I found this to be very, very useful. Yeah, this is another situation where I found this to be useful. Not posterior polar per se, it doesn't help you much, except that it gives you a beautiful central circular 5 millimeter rhexis. And in a situation where you have a posterior capsule rent and you are not able to place the lens in the back, I think it gives you, the optic capture is so good that the centration of the lens is beautiful. So in that sense, it is really very, very useful. That sometimes, people are tense because there is a posterior polar cataract, and therefore they go wrong at every step, and they can go wrong with rhexis itself, and therefore you may not be able to put the lens in the sulcus and center it well. Apart from that, the rest of the things remain the same. The only thing that we do is in hydrodelineation, what we do is we use a nucleus manipulator. There's an instrument which is very nice, which actually tumbles the lens 90 degrees, and therefore there is hardly any stress on the zonules, and the lens is very easily sucked out, and then we continue with the other things. So in that limited sense, zeptocapsulorhexis is useful, and again, as I said, premium lenses, we are using it exclusively. We suggest, like sir was saying, that if you have a femto, then in premium lenses you say that you use femto and we can give you definitely give you better results. So the same way we counsel the patient for zepto. But this is another situation. Old patients come with mature or hypomature cataracts, and the pupil is not very large. And those are the patients you have to be a little extra careful, because these patients sometimes can have weak zonules, and therefore you have to be a little careful in the sense that once you release the vacuum, then you wait for a while and see that the whole bag is not coming, because rarely this can happen in old patients who have weak zonules. The whole capsular bag comes out, and that has happened once in a while. So in mature cataracts, in very elderly, this is a wonderful tool. In sir was saying that in very hard cataracts also this is useful, but then what we have realized is that if the pupil permits, then we tend to enlarge it further more, because the edges of this particular capsulorhexis, though it is claimed that they are stronger than the manual or the femto, but I personally felt that they are a little weaker, and therefore all the procedures that you perform in these particular patients, you have to be a little more gentle than you would normally do. Sometimes there could be a potential pupillary problem. You feel that the pupil is fairly well dilated at 6 millimeters. Anything less than 6, you actually don't use it, because the suction tends to suck the iris as well. And sometimes in the most unexpected way, the iris, if it is elastic, then the suction cup tends to suck the iris, and it becomes very difficult to release the iris and then complete the procedure. So if the iris is sucked, I have a feeling that in this particular machine, it's very important that you should be able to release the suction manually or in some way, so that the iris is not damaged. But of course, if this happens, then you reposit the iris and then you continue with the procedure, and you can do a fairly good job. But this is one of the disadvantages that I found, that if the pupil, if you're not very careful and we are very close to the pupil, then and the pupil is a little dynamic, then it gets sucked into the suction cup, and the trauma remains. These pupils never go round. They have these multiple sphincteric tears, and in fact the iris is split in these patients because of the suction. So this is one of the disadvantages that I found, and therefore I have been more careful now, and wherever I have the slightest doubt, then I put, say for example in this particular patients, I start with using the iris hooks itself, and iris hooks have a benefit over other pupil expanding devices, because what iris hooks do is lift the iris away from the anterior capsule, and you are placing the zeptorhexis probe sort of on the anterior capsule, so the iris never gets trapped in that particular suction cup. And so you have one step extra, but it is very, very safe, to put the iris hooks enlarge it beautifully, and then continue with your zeptorexis. So that is one thing which needs to be done in these patients. Sometimes you tend to rub the iris a little, and so there is a way of pushing the iris back with the repositor and then place it and then center it properly, the Purkinje images, and then fire. Yes, sir. Sometimes, rarely it happens that it fails to fire. That's a very difficult situation where the suction doesn't come. So I have been complaining to the company about this, and they said they are looking into it. So nothing happens, and then if you fire, so what happens is then you release the suction, but it leaves behind a mark which can be used as a guide to, complete your rexis properly. So these are some of the cases where you must take care, and last slide. Next. Sorry, one step. So wish list for the future is that you should be able to create vacuum and release vacuum manually, and there should be a backflush facility in this particular machine. Next. Thank you, sir.
Thank you very much. Thank you very much, Dr. Gadre. You've given a very intensive and detailed analysis of the machine. It's certainly very useful, and it is something which everyone should consider. Now it's there. Okay, it's as I said, it's an excellent machine, and it is something everybody should consider having. It works extremely well, gives good results, and is most important of all economical compared to a regular femtocataract. May I now request Dr. R.C. Shah to give his talk on my experience of the first 100 TriDiff. Dr. R.C. Shah is from Mumbai, a very prolific surgeon. Most important of all, he is also a scientist. He developed new models of optics which can be utilized in difficult situations. We are looking forward to hearing him.
Thank you, Dr. K.K. Mehta, for a wonderful introduction. I thank CARE Group to give me the opportunity for this symposium. I'm going to tell you my experience with trifocal lenses, that is TDIF, made by CARE Group. I did about 300 lenses in 1 year time. It is a unique design. We have a multiple option for multifocality in IOL technology. The refractive one, which is no more available, the diffractive apodized and non-apodized bifocal IOLs, the EDOF, and the diffractive apodized and non-apodized trifocals. Now in trifocal there are two segments. One is a monofocal optics, and the second one is a diffractive elements, which will convert the lens into bifocal or trifocal. Now in designing the bifocal or trifocal lenses, when you decide the space between each ring, that will help us to control the power of addition, and when you see the height, it will help us to decide the distribution of the light near, distance, and intermediate. Now all these lenses are basically designed on a green wavelength, because that is a place that that particular wavelength has got the highest sensitivity on the fovea. So by adjusting the height, that is Z max, you can either increase or decrease the magnification, that is the addition of the multifocality. About 40% of the diffracted light towards infinity, that is for distance, it is known as a zero order diffractions. 40% is towards the near, that is first order of diffractions, and about 20% that is lost in the macula. These can be modified either by changing the height or changing the distance of the mire. Now when you increase the distance between the two mires and make it double, then the addition becomes half, and that is the principle on which the trifocal lenses have been formed. So now when you want to make a trifocal, you make a combination of bifocal and you superimpose the trifocal segments so that every alternate ring will be having a trifocalities. The one which is this portion will be for bifocal and this small portion is for the trifocal, and they are maintaining the same height. So this is known as a non-apodized trifocal. Now if you do the same thing with decreasing the height, it is an apodized trifocal. These are the commercially available trifocals. First one is the bifocal, that is the Restore, where there is no trifocality. Then came the trifocal diffractive apodized, that is Physiol. The third one is Acrylisa, which has got a same height all throughout. And the last one is the Panoptics. This is a unique design in which every two rings are of bifocal and the third ring is for trifocal. I did the pictures on my slit lamp. Now this is a tri-diff unique design. If you see first, second and third ring, you can't make out much about the trifocality, but afterwards these rings, the distance between this and this is half. So each one, if you see now in the peripheral portions, it has got a bifocal and trifocal rings which is seen. As compared to in this Panoptics, you see the two rings are same, the third ring is different, that is a trifocal ring. Now how to switch over from bifocal to trifocal diffractive element? The trifocal IOL, the only trifocal that is a tri-diff, it gives a full range of vision corrections, provides far, near and intermediate vision, balanced contribution, distribution of the light, provides better contrast sensitivity, spherical aberration correction to nearly zero, a pupil independent, nearly pupil independent lens, trifocal IOL. This is the design. This is a plate haptics. Again the same thing which I shown you. The most important, these are the few features of this trifocal lens, that is tri-diff. The optic type is biconvex. This is very important because when the placement of lens is done, the A-scan and everything, this biconvexity is very important for us. Modified refractive diffractive aspheric surface. Haptic is plate haptics, and it has got a 0.26 water contained. This is again very important because if you increase the water content, the thickness changes. A constant is 118.6. Refractive index is 1.46. Again, this is one of the very important factors. If you increase the refractive index, the lens becomes thinner. And in hydrophilic material, this is probably the last available refractive index. The haptic angulation is 0. The available diopter is 0 from 0 to 30. Addition for near is 3.5 and intermediate is 1 plus 1.8. It's a partial diffractive surface, not completely. I think the diffractive surface stops at 4.5 millimeter. The same thing. Now, almost all multifocal lenses have potential to create halos and glares. To tackle these situations, the designing is done in such a way that we have a minimum chance of getting night vision problems. The IOL design attributes plays a significant role for minimizing halos and glares. Halos and glares are experienced in night time. Now what the company has done is that they have decreased the step height and increasing the angulation from center to the edge, ensures excellent light distribution for both focus point near and far with minimum chance of halos and scattering of the light in the night. This is the power distribution of the light for distance, intermediate and near. This is the energy scan. Now it has got a unique property of dynamic energy transfer. The pupil size changes as per the light conditions. Pupil also small aperture when you see the near object, that is because of accommodation. Medium for the intermediate and the large for the distance. When you see for near, energy will transfer more for near and less for the distance. When you see for far and intermediate, energy will be transferring for distance or for intermediate more than the near vision. It has got a dynamic energy transfer of 50% distribution for distance, 30% for near and 20% for intermediate. These are very important factors because ultimately quality of vision for various distance will depend on this. Contrast sensitivity, most of the time we have a MTF, and this particular lens has got very good MTF for intermediate, distance and near, all three. This is the intermediate, this is the classic and accepted MTF graph. It has got a power map which exactly tell you what power the lens is and with 0.25 diopters on either side. It's a unique next generation design which provides supervision for all the light conditions and near, distance and intermediate. I did 300 eyes in last 1 year between the age of 35 and 80. Proper evaluations were done before and after the surgery. OCT, IOL master, pentacam and spherical aberration is done. Epithelial mapping is done whenever is necessary in selected patients. 20 patients, this is one of the most important factor which I found. 20 patients with keratoconus were implanted with Tridif, and that was my error. I detect one keratoconus more than 60 years of age per day. Proper Rexis of 5.5 mm was done, Rexis with the Rexis marker. Perfect centering is done with the Purkinje's, first Purkinje's image. Oh, video chalao na. You have 2 minutes more. Boss, video chalao na. It worked there. The Rexis marker is kept at the first Purkinje's image, which is the brightest. This is the first Purkinje's image. नहीं चलेगा ना?
चल रहा है.
This is another wonderful blade, which is a aspheric blade for money.
Goes like makhan.
These particular lens which I studied, I think it's got a unique design than the rest of the trifocals available. It gives a wonderful near vision as well as the intermediate because it's a unique design which is there. The plate haptics ensures the centration much better than the J optics, especially you need these things when you are doing a multifocal. The only disadvantage of this lens is that there is a small increase in the chance of PCO as compared to the J loop design. In 1 year I had got only one patient which is probably requiring YAG lesion. Now you see this. Again you can see the different distance rings for intermediate and near. The post-operative follow-up 1, 10, 30 days. Near distance and intermediate distance were recorded. Depth of focus was done for all the patients. Almost all the patients behaved the same. Now this is the one thing which I did unusual, which nobody has done so far, to find out the exact performance of the depth of focus of the IOL. Now The factors contributing depth of focus is pupil size, aberration, and IOL design. I studied 300 patients of pupil size on OPD scan. Pupil size is approximately 4 mm for photopic and 6 mm for scotopic condition, and it is approximately 1 mm in older patient. That is one thing where the smaller pupil usually gives good depth of focus in almost all the multifocal lenses.
Chal dost.
Aberrations. Okay.
Yeah, speed kar.
Now, these are some of the depth of focus in dilated and undilated pupils. It is almost saying the same thing. That means the lens, trifocal lens is working very well. This is another trifocal, the tri-diff lens. Again, the depth of focus is almost the same with dilated, undilated pupil. All of them are almost the same. It has got a tolerance of 0.75 diopters on either side, plus or minus, to have a good quality of vision even for distance. So I would feel that even they give a good depth of focus for distance also. These are some of the unhappy patients. I need not, because of timing, I cannot discuss them. So conclusion, tri-diff is a unique design for very good trifocalities. Tri-diff is a minimum incidence of halos and glare. Most of the side effects are because of the reasons other than optics of the tri-diff, and these reasons are very poorly evaluated today. 91% of the patients, myself and the patient both are very happy. Thank you so much.
Thank you very much, Dr. RC, especially the initial slides telling us the details of why and how these multifocal lenses work. Your experience really is very good. I'm so happy about that. It's a great lens. I have also put in a fairly large number of them. Patients are very happy. They all see well. Having said that, we now move on to IPCL, the complete refractive solution by Dr. Kamal Kapoor. As you are aware, the IPCL is one answer when nothing else is available, and it gives you the ability to control the power irrespective of the cornea. And a well-fitting IPCL is something which is a thing of beauty to watch and observe.
Yeah, got it. उधर आ गया? इधर आया? Okay. Can I have the lights off, please? Okay. I must thank Care Group for giving me this opportunity to share my fair experience with the IPCLs. I think I've used a fair number of these, if I'm not wrong, probably highest I've known. And I've had my shares of issues with the design to start with, but I think by now the thing is stabilized and it's just perfect. We all know there are innumerable options available now as compared to a few years ago in the phakic segment. I'll have to go fast because I have to leave some time for the following speakers. The best thing about the lens is the design, the way it contours up, the way it takes in the high vault and the low vault. I have cases of very high vault up to 1200 microns, and the patients are doing well. I've even had case where the patient had suffered a tennis ball injury and the vault had gone down due to some trauma and the zonular loss. The vault was 110. The patient was working for nearly 8 months before he saw me, and there was no cataract. So that goes a long time for the design and the centraflow hole. Let the numbers speak. Approximately, I think nearly 1200 plus. This is a slightly old slide. 124 of model V2. I've done piggyback, pseudophacus, corneal scars, post-traumatic cataracts, clearless extractions, piggyback in patients operated elsewhere with multifocal lenses, with residual refractive errors. So I've done all. Name a thing, I've done all. I put IPCL in practically everything. Astigmatic correction to 11 diopters I've done. I've corrected till minus 34 diopters of myopia. And the best part is I've taken care of pupil sizes up to 7.8 millimeters. I don't think there's any lens in the world which can tackle that. And I think the credit for that goes to the creative and the R&D team with the Care Group, because they actually giving us the muscle to the Indian ophthalmologists to tackle these cases, which I'm sure will be said no to in a lot of other places. The design is very, very typical. If I can use the pointer, there are 6 holes here and there are 2 pointed holes here. There's a unique design of the haptic pad. This haptic pad can actually take in a lot of compression and will still not vault. And even if it is on a lower vault, it still rests beautifully. And the central hole, which is again tapered, will not give you halos. I have incidents of explanting ICLs because of halos. The patient is absolutely emmetropic,
but he had halos, so I've explanted them and put these lenses, and the patients are happier now. This is a subset of 300 last patients. The care group asked me to do a study on them. I was just doing high volumes. I was not following them up. I started doing a study. If you actually see, majority of lenses are 12.5, nearly 97%. But yes, I've got even small sizes. Our experience in numbers, again, this has gone back. Okay, now, walled patterns, only 7% were shallow walled. If you see, most of them are lying within 400 and above 750. Even 750 microns and beyond, the lenses are behaving beautifully. Post-operative 3 weeks onwards, if you actually see, this is the net result. Now, some of these patients are high myopes and they're amblyopes. So don't look at frown at seeing 618. This 618 probably is the best vision this patient ever saw. A girl with minus 31 or minus 32 and chorioretinal degeneration, macular degeneration, what will she see? But this is what has transformed her life. I'll show you some photographs as we move along. High refractive errors, what have we done till minus 32? Moderate refractive errors, corneal scars, astigmatism, 11 diopters, exceptional corneal sizes, we'll see some videos. We also have presbyopic lenses. We have presbyopic lenses to correct patients who want near glasses. What I've done is I actually feel there's a new category opening for all of us. Any cataract patient you operated 8 years ago, he comes back to you and now he talks to another person where you put a multifocal lens and he says, Doctor Sahab, usko to paas ka bhi dikhta hai, why not me? So you say, okay, I have offer something you. When I operated you at that time, this technology was not there. I can offer this to you. You can put in a presbyopic secondary piggyback IPCL in these patients. Not to mention, there's another technique called the add-on lens by care group again, but that's another topic by itself. Post-cataract refractive errors. Now, I'm going very fast. This is the leading mark. These are the holes which need to go superiorly. This is the toric alignment. The best part about this lens is you do not need to dial this lens. Read my lips. You don't need to dial this lens. Just mark 0-180, put the lens in, and that's it. No need for secondary marking or secondary rotation. And I feel in my study, the best, most happy patients are patients with high astigmatism. You can imagine you have a patient with 6 diopters of astigmatism and you go off mark by 10 degrees. This patient is going to hate you. But what if your marking was accurate and the lens manufacturer was actually accurate to the last degree? Once you put this lens, this patient's life transforms. The quality of village. This is one thing which was wrong with the ICL. There was a straight cut was causing diffraction. What they've done is tapered the cut on the side so it reduces the diffraction and increases the aqueous flow from behind into the funnel method. I'm going very fast. The compression pad. The best advantage with this lens is you will get 2 lenses with each order. In case, God forbid, you drop one, you crack one, you break one, and the patient is on the table, you don't send the patient back. So the company sends 1 extra lens with you, which you can return back to the company. And it adds to the company's inventory. So next time you need a similar power, it comes within 2 days. I think that's a wonderful idea. It needs a lot of thinking to think like that. Marking. Now this is what you do with the IPCL. You just align it 0-180 and that's it. Nothing to do. This is 4 years post-op. Perfectly aligned. 0-180. No dilatation. No rotation. Advantage of a non-animal source. 6 pads. 4 micron into 3 times the hole. So the amount of aqueous flow which is coming, you see most of the time the IPCL or ICLs were being blamed for coming in contact with the anterior capsule and causing cataract. But studies are coming in, it was more of aqueous stasis between the IPCL and the anterior capsule which was causing the cataract. So if you have the aqueous flowing through, the incidence of anterior polar cataract is 0. In my study, we just had some traumatic cataracts and some patients where I put an IPCL after 3 years, high myopes, they had a retina detachment surgery, post silicone oil, they had a cataract. These are the only cataracts I have to report. Now, again, I'm going very fast, sir. I hope I don't eat into the time of other speakers. This is what you do. You put in a viscoelastic, and that's the beauty of the lens. The lens unfolds so beautifully, so softly, and all you need to do is align the lens, 0-180. These are the marks you need to align. This is my 0. This is my 180. You align the lens, and it's ready to go. There. The surgery is over. And we'll see now one or two tricky situations. Again, I won't go. You have large sizes lens, minus 17 with minus 2 diopters, both eyes operated, minus 27 with minus 3, both eyes operated, minus 15, Two twin brothers, one got operated, he was so happy, the younger brother was afraid, he said, "Pehle iski karao, tab main karaunga." So when this guy got him for the next surgery, -12. So this is again, this girl had retina detachment after 2 years in the other eye. This was the one I was talking about. -29 with 2 diopter cylinder. Now this is again a lens manufactured again specially for us at an 8.5 millimeter. You'll have to see the actual optic to believe it. See the size. Which company can manufacture this lens for you? Only Care Group. I have no commercial interest, please. See the size of the optic. This patient was actually any other phakic lens you would have put, he would have had glares and halos. Another part is the material is so beautiful, it can be so easily withdrawn and put back again. You see, I put the lens wrong side accidentally. I had a new OT technician who loaded it wrong, and I realized it's wrong. I just go in and it rotates. I'll also show you an explantation. Now this is a patient operated Symphony somewhere else. He had a +0.5 residual refractive error, and what do I do for him? I had a choice of either explanting the lens. Last 2 years I've stopped explanting any lenses. Any refractive errors, just pump in an IPCL on top. Because the lens is around 80 microns. Post cataract removal, the anterior chamber depth is anything between 4.2 to 5.7 millimeters. You have a good open angle. You can push in an IPCL anywhere you want. So this is what an IPCL does. This was a very high premium patient operated by one of my friends in Delhi. The lady was very unhappy. The surgery was fine, but there was some refractive error. And this patient is 6'6". This is what you can do with the technique. Another patient post-traumatic operated 17 years ago. He landed up with -17. Very interesting situation. I'm sure none of us would think of even explanting this lens. Completely fibrous with Sanique. So what do? I go in, I cut the Sanique, cut the capsule, a -17 IPCL I put in a patient operated 17 years ago. And you will also see the corneal scar in this patient. He had an astigmatism. There, this is the corneal scar you see. And I push in an IPCL, patient touches 6'9". This is the patient post-op. Oh, it jumped. Yeah, this is the patient post-op. Now another patient with corneal scar. Again, huge astigmatism. I'll just jump very fast, sir. You have to see the corneal scar. This is the corneal scar. 11 diopters of astigmatism. Either you do a keratoplasty for this patient, what else can you offer? This patient is 6'12". We do a 11 diopter cylinder with -3.5 sphere. Again, corneal scar, I'll skip the video. Corneal scar, -5 diopter cyl with -4 myopia. Small scar. This patient again improved. So majorly no explants. We had these kind of situations. We have 297 volt, 848, 1008 volt. No issues with the patient. In case you feel there's a cataract happening, wait. This could be a retained viscoelastic. This is what you see. 4 days afterwards, it starts clearing up. So this is not cataract. This was probably retained viscoelastic behind the lens, which you forgot to remove. Progressive lenses, we've started doing in, I'm going very fast. Progressive lenses, presbyopic lenses, IPCL for your pseudophakic patients and patients in presbyopic age group. I think I did well, sir. I skipped a lot of videos. Thank you.
Thank you very much, Kamal. You've done a really excellent job, and IPCLs are now come of age. It is something which has to be in everybody's armamentarium, and we look forward to everyone using these lenses so that in future we can really have a session just on IPCL to see how well it works and to give the results to everyone. Thank you very much. Our next speaker is Dr. Rakesh Shah, who's going to speak on IMAX Mono, Hope for ARMD Patients. Na?
Good afternoon, friends. Thanks to Care Group and AIS for giving me opportunity to share my experience on IMAX Mono. Though they were recommended IMAX Mono is a hope for ARMD, but I would say it's not only hope for ARMD, but also for non-ARMD patients. No financial interest in any product shown here. IOL AMD or IMAX Mono IOL is a unique approach for extending and improving the visual function in a patient with in patient with maculopathy for various reasons, not only for AMD. So what do we options we have currently for all these macular scar? So we had previously Prism, which we can put in the glasses. We had similar implants in the past like IOL VIP or Revolution or IOL AMD. There were dedicated low vision aid glasses in terms of external visual aids or the different implants which are available. These are the few of the pictures which are currently available internationally about the telescopic IOL. Though the previous one and this is the current one. The old IOL, the telescopic IOL are the very big, bulky and is very difficult to put. There are a lot of other pros and cons for that lenses, and this is the current IOL AMD or IMAX mono what we have. These are another lenses which is currently available in the market. And all these lenses basically have some telescopic effect or maybe the little decentration, but then the procedure itself is very tedious to do it, and it's very difficult to convince patient about these lenses. We had a previous version of this AMD lenses, that is a Hubble IOL, which is a combination of two lenses, that is a minus and the plus, but again it has a little different procedure to operate. Now currently what we have is IMAX mono, jointly developed by LEH Pharma, Dr. Pablo, and the manufactured by Care Group in India. I was behind this telescopic technology for last 4-5 years and currently working on that. We had this evaluation history starting from 2006 when Dr. Bobby Qureshi had done a first implant, and then currently in 2016, and then followed by now 2019. So what is IMAX mono? It's a combination of two lenses, which is a combination of minus and the plus. It's a small incision. It works like a small hydrophobic acrylic lens now, implanted in the capsular bag, and it has a very advanced optic in terms of wavefront optimized and super aspheric design, which gives not only magnification, that is a telescopic effect, but it decenters your image to a preferred retinal location by at least 10 degrees. So it is put in the capsular bag. It's a proprietary their design. They don't disclose the design, and really I don't know what is actually in the design, but what I understand is hyper wavefront modified, and it decenters your image by 10 degree. It gives a magnification of around 0 to 220 degree, that is around 1.2x. So what we understand from our optics, which at the fovea we have crisp clear vision, and the surrounding parafoveal area where the vision is relatively less. And all these macular disorders patients in the fovea will have very clear vision, but on the periphery once you go from 20-30 degree, vision will keep on going down. Now because of their central scar, they are not able to see in the center, and that's what we have to have is a parafoveal, the vision stimulation which we have to do. So what is the standard monofocal IOL which will be giving vision only in the center part, but the surrounding area will not be utilized. So what we get in the standard monofocal IOL is only the central vision, while the parafoveal area what we are getting now in the IMAX mono is what I am stimulating is a parafocal area. So similarly, there are a lot of questions in the previous talk where, not here, but other session where you can use a simple prism and get the same type of vision. But only prism will give PRL, that is a preferred retinal location at only one particular point. It will not work on all the areas. While IMAX mono works in the entire area, that is around 10 degree in a diffuse way. So we really don't know which is the area which is healthy and which is the area which is unhealthy where we can actually stimulate. So what is getting in IMAX mono is stimulating the vision in the parafoveal area. So we are basically working on the stimulating the image on the parafoveal area and magnifying the image. And with glasses for distance and near, it still works. It gives little better magnification with +3 glasses when we use post-op. So these are different magnification what we are getting from IMAX in the distance and the near. I'll go with the indications what I have currently used. That's the dry and scar ARMD, the macular dystrophy, the best disease, macular scar due to other causes, and myopic macular atrophy. There were the initial criteria for AMD patients, which I have slightly modified for my criteria. What we do is a vision uncorrected and the best corrected vision with the glasses. We use a various types of telescope as a low vision aids, color and contrast vision, fundus, and the OCT. The visual which is the most critical, and the trial of low vision aids and the alternate patching for both the eyes for at least first 3 months. Patients should understand it's not something magic what we are doing. They already have a bad retina, they don't have a central vision, and we are getting something for the parafoveal areas to work. But they has to understand what is that parafoveal area and how I can see from the side. These are the patient suitability lens chart what AIOCare people provides. These are the few cases which I have done. My first patient, yes, it was a dry RMD which got backfired. I have not put their photographs, and then we just lens came and we had put, and then there was actually the retina got there was a swelling on the retina which actually got backfired. But these are the other cases which I'll show. These are the Stargardt's macular dystrophy patient. These are the first two which I did bilateral. These are their initial OCT pictures. The first patient we could not do perimetry because which I didn't realize in the initially we just had OCT and fundus pictures. For me, the critical part is the initial low vision trial. So my optometrist does a very good job about giving the telescope. We make them to patch one eye and see with the other eye alternately at home, and then we make them to use this low vision. There is a telescope. What we have seen is with IMAX mono, which is 1.2x, it works equivalent to around 3x telescope currently. Though patient get better vision with 6x or 9x, but what currently which is getting a 3x telescope is almost equivalent to what I am getting in the IMAX mono lens. So these are the different telescopes which are available in the market. You can show different types of telescope to the patient. And then actually they see with each eye and see how much is the stimulating. In my practice, I have seen binocularly when it works better. The basic concept, it has to focus on the peripheral 10 degree and binocular. Both the eyes has to work together. So this is the first patient. The initial vision was hardly 3 feet, and then post-op he has improved to almost 618, 612. They are very happy family with their, came from the village, and practically this boy was not working, and then it started now his routine work, it started driving also.
Can you summarize, please?
Yeah, it's time. These are the other case, the Stargardt macular dystrophy, the other lady which I have done. I would like to show the perimetry part. There is a pre-op, before surgery, and the post-op. They actually shift their preferred location, and you can actually see the magnified and the field of vision also enhancing after the surgery. This is the third patient, large macular chorioretinal scar post-choroiditis, and even this patient had worked very well. This is a pre-op, and that's a, and this is the last patient now which I have to just operate. He is still undergoing the LVA trial, and probably in next month I am going to operate this patient. The surgery remains a standard like a normal cataract surgery. We don't have to do anything fancy for the cataract surgery. It just just a standard of hydrophobic acrylic oil. What other? Thank you for a kind attention. Thank you.
Thank you. Thank you very much. It is really a very innovative system, and especially for those who are afflicted with the problems of vision, it is the answer which everyone is looking forward to. I think we probably need a little more time, and we should be able to get more and more data out for this lens, which is a very innovative concept. Must congratulate Care Group on doing it. They have always been innovators in the field, but I think they have really covered themselves with glory as far as this particular lens is concerned. I will now have the last speaker. I hope he has enough time, Dr. Umesh, speaking on the improving the quality of vision with toric lenses.
Yeah. Good afternoon, everybody, and thank you, sir.
Are the next session 2:30?
I'll try to make it fast. Not opening.
Not opening. Very fast.
I will be talking about the ultra smart toric. As all of you know, we have among the premium lenses segment, we do have a lot of toric lenses available in the market, and
Not loading? Because we have run out of time, unfortunately.
not very fast.
No. Any camera? I think we'll just have to call it a day. I'm so sorry. Would our next group like to now take over, please? I know, but what to do? We can't delay the next ones. And is it open? Acha, okay. Okay, you have 2 minutes. Okay, carry on.
I will try to rush as fast as possible.
Okay, Umesh.
Yeah, the available toric lenses that are available in the market have quite a significant lengthy protocol, like calculating and making a reference mark and rotating, and also making sure that the final alignment of the IOL and the chances of errors in doing such thing is quite significant also, unless we have the advanced technologies. The advantage of the ultra smart toric that we have is a fully customized tailor-made IOL for each eye, and as you see, it's also a hydrophilic acrylic plate haptic IOL. The customized optic profile and overall length for each patient has been customized, and that is got by measuring the white to white for individual patients, and which ensures predictable refractable outcome. The plate haptic design with anti-rotational haptic pads, that's what is very important here. And also the white to white customization ensures that there is no rotation of the IOL in the bag, which is very important for the to maintaining the toricity. And the ELP, the optimized ELP design based on the axial length and capsular bag, it takes into consideration when they calculate the capsular bag size and ACD, which will give predictable outcomes. And of course, the incidence of PCO. Theoretically, they say because the size of the lens is customized, the PCO should be less. The biggest advantage is no axis marking, no alignment, and the incision is not mandated on the steeper axis. I'll try to skip the video and just go through. That's the unique lenses. As Kamal was telling us, the amount of astigmatism you can correct up to 13 diopters. That is what we have done. 16 diopters in one case for PMD. Of course, the outcome was very variable in that, but up to 13, if the cornea is regular, we can go ahead and do. That's the beauty of these lenses. In the competitive lenses, we get up to 3.5, maximum 3 and 3.5 is what we get. But here, you have to just talk to the engineers, and they will try to do the best for you. That's the best part that I have seen here. And these are some of the lenses that we have implanted. We did a study for 2 years, and this we made it a part of our post-graduation thesis for 2 years to analyze. The primary objective was to measure the residual astigmatism following customized toric IOL, and of course the secondary to whether the preoperative amount of astigmatism and the ELP what they claimed was right or not. So that's the materials. 45 eyes, 90%, 5% statistical power, and 5% level of significance. Single group open label prospective clinical study. All the inclusion criteria were there. The mean age group was around 62 plus minus 11, 30 to 80 years. And the cylinder in this study I took up to only 6 diopters. Now the residual astigmatism in post-op 1 and post-op 2, as you go to post-op 2, the residual come down to 0.7. As you see, that's with the rule. The against the rule obviously gives the better results, and the visual acuity is on par. The mean pre-op corneal astigmatism what we took was around 3.5. The mean post-op on first follow-up was 0.5, and mean post-follow on residual astigmatism on second follow-up was 0.4. When we compare the study for referrals, the Medicute et al., which showed the mean refractive cylinder decreased after surgery was from 2.3 plus minus 1.28 to 0.75 at 1 month post-operatively, as frail significantly better than that. The percentage of eyes having residual astigmatism less than 1 diopter post-operatively in our study was 93%. The study by Brewer et al. Was 91%, definitely better than what we showed. Of course, this was a short study of 45 cases. And to conclude, according to the results of our study, customized toric IOL, which is the ultrasmart toric, provided comparable and better results to the standard toric IOLs. The rotational stability, the ease of use, because it's in one go you put, and there is no need to mark, no need to do additional calculations. The plate haptic design with anti-rotation plates definitely ensures less rotation, and customization can be done even up to 15-16 diopters of cylinders. Thank you.
Thank you very much, Dr. Umesh. That is a very nice paper. It is an excellent concept and really works very well. I've used quite a few of them also, and one of the biggest advantages, you no longer have to bother doing anything. You just need 1 by 180 and that is it. May I request the next team to please take over with our apologies. But unfortunately, as I said, we got the hall a little late.